Hello there! Welcome to your FASTHUG orientation. My name is Ryan. I'll be your tour guide on this safari through checklists that aid in patient care in the ICU. Please take a seat. I understand you may be nervous. This may be your first stay in the ICU with many new things to learn. And you're thinking, some guy in the computer is going to tell me how quickly I should hug my patients? What? No. Don't worry. FastHug is not actually direct instruction on the speed or velocity of which you should touch patients. It is actually a checklist that ensures we provide adequate care for all patients within the ICU. Strap yourself in. This might be a bumpy ride, but by the end of it, you'll have the skills needed to consider the many complex aspects of an ICU patient and their care. Objectives for this lecture include understanding how checklists and protocols can aid in patient safety. We'll define the FASTHUG Mnemonic, and then we'll apply it to patient care. Hey, look, a cheetah! Checklists provide additional safety when there are many factors to consider before completing a task. They remove human error and prevent slips or lapses that might result in the omission of a consideration and lead to a negative outcome. For example, when you wake up in the morning and prepare for work, you ensure that you are wearing all of the appropriate clothing. Multiple times throughout my residency, I have forgotten to wear a belt to work. If I had a checklist that required me to assess whether or not I was wearing a belt each morning, I could have avoided this omission and all of the negative outcomes associated with it. Other high-risk industries also use checklists, such as pre-flight checklists in aviation to ensure all necessary aspects have been assessed before takeoff, or a preoperative timeout in surgery to ensure the right area has been marketed for operation and all tools are available. This illustration demonstrates the many complicated factors that ICU physicians and other healthcare workers in the ICU need to consider regarding their patients. Medications, dosing, renal function, whether or not their blood is being filtered, or if they're on hemodialysis, antibiotics. As you can see, we must consider a great deal of factors. And for someone who can't remember to wear a belt to work, a checklist would be a wonderful aid in ensuring each one of their patients receives the care they deserve. So what exactly is this FASTHUG you've heard so much about? The individual components are listed here. We'll go through them each on a separate slide. Feeding, analgesia, sedation, thromboembolism prophylaxis, head of bed elevation, ulcer prophylaxis, and glycemic control are core things that should be assessed in your ICU patients each day. The F in FASTHUG stands for feeding. Just like in the great wilderness, all life must feed, including your critically ill patients. Malnourishment in the critically ill has been associated with infectious complications, increased risk of ulcers, long lengths of stay, and mortality. And for that reason, we must ensure that our patients are receiving adequate nutrition. ASPEN, a dietary council, and SCCM, the Society of Critical Care Medicine, recommend starting enteral nutrition, or gut nutrition, within the first 48 hours of ICU admission. Parenteral nutrition should be considered if the patient has not been able to receive some form of enteral nutrition after 7 days. What should be assessed in the ICU patient when considering feeding? The first is, can the patient be fed? While ASPEN and SCCM do recommend starting enteral feeds within 48 hours of ICU admission, there are some stipulations. One, for example, is, does the patient require further resuscitation for hemodynamic support? If the patient is requiring fluids or vasopressors, they may have enteral feeds delayed until they are more stable. Other considerations could be, will the patient require further procedures? A patient who is at a high risk for intubation or is going to have a trip to the OR may be made NPO, or nothing by mouth. This is to reduce their risk for aspiration during the procedure. Aspiration can lead to negative outcomes such as aspiration pneumonia. Other considerations are, what are the patient's nutrient requirements? A dietitian will work closely with the team to help determine these while you are rotating in the MICU. A very important consideration is what is the route the nutrients will go through. A general rule of thumb is that if the gut works, use it. We can give enteral nutrition either orally as a regular diet or through a nasal, oral, or percutaneous tube. If oral is acceptable, does the patient have a diet ordered? And is it appropriate for any swallowing restrictions that they have? If it is going through a tube, do they have tube feeds ordered, and are they continuous or intermittent? This can be checked on the diet orders link under your sidebar in Epic for both whether a diet is ordered and whether or not tube feeds are going. We must also consider if the patient is on any medications that will interact with their tube feeds or diet. Two, for example, would be phenytoin and levothyroxine. Phenytoin interacts with tube feeds as well as levothyroxine, and we should ensure that it is being assessed that tube feeds are stopped before the medications are administered. Lastly, if the patient requires parenteral nutrition, we should evaluate if they have a central line. TPN is highly osmotic and can cause significant phlebitis if given peripherally. We should also consider when the TPN will be stopped. Having TPN is a high risk for infection, and the patient should receive it only as long as necessary. One further consideration is what caloric contributions are coming from their medications. Medication suspended in D5W, or dextrose, in water will provide some calories, and medication suspended in lipids such as propofol, a sedative, will also provide calories. The A in FASTHUG stands for analgesia. You'll have a more in-depth discussion on analgesia and sedation later in your rotation, but we'll briefly touch on it here. Critically ill patients feel pain from their illness, devices like endotracheal tubes, and routine procedures such as suctioning. Patients who have improved comfort also have improved healing. So we should assess that an appropriate pain-relieving medication has been prescribed for each patient, and we want them to avoid suffering and pain, but not have excessive analgesia as well. Assessing analgesia in the critically ill patient should assess whether their pain scores are at goal. If we are noticing consistently high pain scores, we should recommend an intervention in order to improve these. Not all patients will be able to verbalize their pain. Some patients will have a decreased mental status and be unable to communicate, and others may be intubated and sedated and unable to verbally communicate. In these scenarios, there are a variety of scales, such as the visual analog scale or the CPOT scale, that can help us determine if their pain needs are being met. Utilizing grimacing with pain, withdrawing to pain, and inappropriate vital signs such as persistent tachycardia in combination can also be useful to tell us if our patient's pain is adequately being treated. There are many options of pharmacologic agents to use, and ideally we should match the pharmacodynamic effect of the agent with the comorbidities of the patient. We also want to avoid undue mental status changes or sedation from the medications, and avoid any possible side effects such as constipation with opiates. We should assess also if a PRN bowel regimen has been ordered if a patient is on an opiate. The S in FASTHUG stands for sedation. This is another topic that you'll get a more in-depth discussion on later in your rotation. We care about sedation because improved comfort improves patient recovery. We must ensure that the candidates for sedation, which generally are intubated patients, have adequate depth of sedation and the most appropriate agent ordered. We are aiming for a level of sedation known as calm, comfortable, and collaborative. Evaluating the depth of sedation in our intubated patients can be done through an assessment score, such as the Richmond Agitation and Sedation Scale or the Ramsey score, which provide a numeric value to correlate with the patient's level of comfort or agitation. We want to avoid oversedation as it can lead to increased ICU length of stay and duration of mechanical ventilation. Some sedatives, such as benzodiazepines, can also lead to increased delirium in the ICU with oversedation. There are multiple options for pharmacotherapy, and the mainstays are benzodiazepines, propofol, and dexmedetomidine. We must individualize our treatments to the patient. Some patients will require no sedation at all due to their mental status, though this is relatively rare. The T in FASTHUG stands for thromboembolic prophylaxis. In the FASTHUG safari analogy, if the impact of a pharmacist's intervention on this phase of care was directly correlated with the size of the theoretical safari animal, this would be a magnificent elephant. DVTs are a preventable outcome of ICU stays. They can lead to pulmonary embolism, which can lead to mortality, and if they don't, they still require 3 months of anticoagulation after identification. Critically ill patients are at a high risk for developing a VTE or a venous thromboembolism. Virchow's triad, a postulate of the risk factors needed to develop an embolism, states the patient must have hypercoagulability, endothelial damage, or abnormal blood flow in order to develop a clot. ICU patients have abnormal blood flow from extended periods of immobilization due to mechanical ventilation and sedation. Endothelial damage can occur from vascular injury from their disease or from surgery and procedures needed to treat the patient. And hypercoagulability may exist in a variety of ICU illnesses, such as disseminated intravascular coagulopathy. The guidelines from CHEST for DVT prophylaxis in the critically ill state that the incidence of DVT can be as high as 81% in a critically ill patient without prophylaxis and 44% still despite prophylaxis. Because of this, we need to ensure that all patients receive DVT prophylaxis unless contraindicated. To prevent venous thromboembolism in an ICU patient, we can use mechanical or pharmacologic prophylaxis. For pharmacologic agents, we have heparin, enoxaparin, fondaparinux, the new oral anticoagulants, or patients may be on therapeutic anticoagulation for other reasons. Heparin is given as 5,000 units 3 times a day subcutaneously. There's no requirement for change in dose due to renal dysfunction, which is beneficial in an ICU patient population with dynamically changing renal function. However, the drug may be underdosed in the obese population, so occasionally you will see orders for 7,500 3 times a day, depending on the BMI of the patient. Similarly, in smaller patients, the dose may be limited to 5,000 units twice a day. Lovenox, or enoxaparin, is given as 40 milligrams subcutaneously once a day. It, however, does have its dose increased based on the BMI of the patient to 40 or 60 milligrams twice a day. We avoid this medication in a creatinine clearance of less than 30 mils per minute, which may be common in the ICU population, and we often will not see it used. Fondaparinux is given as a sub-Q injection, 2.5 milligrams once a day, and we avoid this in patients who are less than 50 kilograms. However, our institution does not carry this, so it will not routinely be done while you're on rotation. New oral anticoagulants are appropriate for DVT prophylaxis in specific population and is more often studied in a surgical population. However, they have a long half-life, and some of them do not have reversal agents available. Due to the need for urgent procedures in many ICU patients, the tendency is to use an agent that is not renally dosed, has a short half-life, and is easily reversed. Heparin is most often used. If a patient is on therapeutic anticoagulation for any other reason, they do not need DVT prophylaxis. We must assess daily in our ICU patients their candidacy for DVT prophylaxis. If a patient is a high risk for bleeding or has an active bleed, they have a relative contraindication to a pharmacologic agent. Examples of this would be a suspected gastric bleed that has not yet been ruled out or treated via endoscopy, or a patient with a thrombocytopenia, meaning a platelet count of less than 50,000. Other patient populations, such as a head bleed, have a fluctuating need for DVT prophylaxis. Initially, it is contraindicated to their bleed, but once the procedure is done to fix the bleed, they are actually at a higher risk for clots and will require prophylaxis down the line. Some patient populations, it is controversial whether or not to start prophylaxis, such as liver failure or coagulopathy, due to concerns as to whether their risk for bleeding or clotting is higher. All these examples are simply to illustrate that each day we should assess the patient's need for DVT prophylaxis, and if it is unclear whether or not they are a candidate, we must bring up the risk-benefit relationship with the provider and have them assess whether to start it. If the patient does have a contraindication to DVT prophylaxis from a pharmacologic agent, we should ensure mechanical devices are ordered, such as sequential compression devices. We should also consider if the patient is going to be going for a procedure. Do we need to hold their DVT prophylaxis in order to ensure that there is not unnecessary bleeding during a procedure? If an agent is ordered, we should also be assessing the dose. Many of the agents need to be adjusted for weight or renal function. We should also assess if the appropriate labs are being ordered, such as a hemoglobin and hematocrit and a platelet count. If patients are on heparins, we also want to assess that they are being monitored for heparin-induced thrombocytopenia. There is a guideline on the Froedtert Scout page to provide more information on that. The H in FASTHUG stands for head of bed elevation. This elevation can reduce aspiration events and pneumonia risk in mechanically ventilated patients. We should ensure that the head of the bed is elevated at least 45 degrees, and this can be done via a visual assessment on rounds. However, if I were to correlate this with the direct impact of pharmacist care and the size of the theoretical safari animal, it may be more of a small sparrow in a tree, and we should not be overly concerned, as this is typically more addressed by the nursing staff. The U in FASTHUG stands for ulcer prophylaxis. What kind of ulcer? Stress ulcer prophylaxis. As you can imagine, an ICU stay is very stressful on the human body. There are changes to gastrointestinal blood flow as well as decreased gastrointestinal mucus secretion. This can lead to erosion of the gastrointestinal endothelial cells from the natural acids that are secreted within the stomach. It is estimated that the incidence of overt gastrointestinal bleeding is anywhere from 1.5 to 15% in patients without prophylaxis. This is an unnecessary and avoidable complication of an ICU stay. If we take the time to ensure all appropriate candidates receive prophylaxis, we can prevent this. Provision of acid suppressive therapy for stress ulcer prophylaxis has been correlated with an increased incidence of negative outcomes such as C. difficile superinfection and ventilator-associated pneumonia. Because of this, we should always assess that only the most appropriate populations are receiving this. The ASHP guidelines for stress ulcer prophylaxis in the critically ill recommend that those with a major criteria receive prophylaxis. Those are mechanically ventilated patients for greater than 48 hours, those with a coagulopathy, patients with a prior history of ulcer or who are being treated for an ulcer at home, and TBI, spinal cord, or burn injury. Patients with minor criteria may be considered but do not necessarily need prophylaxis. That is septic patients, ICU stays for more than 1 week, occult GI bleeding for 6 or more days, or glucocorticoid therapy, defined as 250 milligrams of hydrocortisone or equivalent daily. Froedtert also has institution-specific guidelines, which includes organ transplant, organ failure, patients on dual antiplatelet therapy, and patients on anticoagulant and antiplatelet therapy. We must assess the risk versus benefit with the increased incidence of negative outcomes as opposed to the likelihood of a stress ulcer in each patient. Other considerations for choosing an agent would include, is it what the patient was on at home? Does the medication need to be adjusted for their renal function? And are there any medication interactions between the selected agent and the patient's home or current medications? Available agents for stress ulcer prophylaxis include histamine 2 receptor antagonist or H2RAs, proton pump inhibitors or PPIs, sucralfate, and calcium carbonate. The mainstays of therapy are H2RAs and proton pump inhibitors. Sucralfate and calcium carbonate have been shown to be less effective than an H2RA for stress ulcer prophylaxis, and they both require frequent administration. Sucralfate also has many drug interactions due to its ability to prevent some drugs from being absorbed. H2RAs and proton pump inhibitors increase the risk of a C. difficile superinfection and ventilator-associated pneumonias. H2RAs cause less acid suppression than PPIs, which has been theorized as one of the reasons that they increase the risk for C. diff. However, the clinical correlation has not been shown here. Each have their own unique interactions and side effects. H2RAs have rarely been associated with thrombocytopenia, and they may cause drowsiness from H1 receptor agonism. Proton pump inhibitors have a variety of long-term side effects to be concerned about. In the short term, we can be concerned about a rebound increase in acid secretion after withdrawal of the agent from continuous use. The G in FASTHUG and our final part of the mnemonic, glycemic control. Appropriate blood glucose control can impact outcomes in the ICU setting. Hyperglycemia and hypoglycemia both have been associated with increased mortality, length of stay, and infection in ICU patients. We must ensure that adequate glucose control is obtained either through pharmacologic methods or through monitoring of the patient. When evaluating glycemic control in our critically ill patients, we should evaluate if their glucose levels are at goal. There have been many studies in a variety of critically ill populations ranging from septic patients to cardiothoracic surgery patients, evaluating strict versus lenient glucose control and differing maximal target glucose levels. This is beyond the scope of our presentation, but know that for your MICU patients, a goal of 90 to 180 milligrams per deciliter is okay. If we believe that their glucose is not at goal or that it won't be at goal based on a history of diabetes, we should ensure that insulin is ordered. Discussing the intricacies of each insulin is also beyond the scope of this presentation. Know that typically for tube feeds, we will use regular insulin, as tube feeds may be continuous and regular insulin has a longer duration of action. For oral diets, we will use Humalog as it more closely mimics the intermittent spikes of insulin that go along with an intermittent feeding diet. For a diabetic ketoacidosis patient, they will usually be on an insulin infusion during phase 1 of DKA, and during phase 2 they will be transitioned to a sliding scale insulin of regular or Humalog. And all patients should have a long-acting insulin ordered with these if they're requiring insulin. The long-acting is to cover their basal insulin needs, meaning those beyond that of exogenous sugar coming from their diet. We should also evaluate if the patient has a prior history of diabetes, whether it is type 1 or type 2. A type 1 diabetic may be more sensitive to exogenous insulin as their blood sugars are elevated due to a lack of circulating insulin. Type 2 diabetics may not be as sensitive to our insulin sliding scales as their sugars are elevated due to a metabolic disorder and an insensitivity to their own circulating insulin. Patients with insulin orders should have hypoglycemia protocols in place, and we should also evaluate whether changes in the patient's diet status or new medications such as steroids will affect their blood sugars and require modifications in their insulin regimens. While we have just detailed the many different parts of FASTHUGs, there are a few other mnemonics. FASTHUG's BID adds in spontaneous breathing trials, consideration of bowel function or bowel regimens, indwelling catheters, and de-escalation of antibiotics. Another mnemonic, MAIDENS, gives a special focus to pharmacist duties, and while it's not necessarily ICU specific, it's a reminder of the assessments we should be making on our patients each day. Medications, antibiotics, indications, dosing, electrolytes labs, interactions, and stop dates are all important parts of the pharmacist intervening on pharmacotherapy. Find a mnemonic that works for you. Whatever it is, as long as it allows you to adequately assess your patients each day, it will work great. Congratulations! You've completed your safari through the wondrous world of FASTHUG. Now that we've geared you up with the skills needed to take care of ICU-level patients, it's time we apply it. On the next slides, you'll find a practice problem. Apply the mnemonic FASTHUG to the patient information and write down what interventions you'd like to make, or what interventions you don't need to make and why. We'll go over the answers. There'll be a section for you to pause. Make sure you pause to write down your answers. Take this time to assess what interventions you would like to make to ensure all appropriate cares are being done for your ICU patient. When you're done, go to the next slide and we'll discuss the answers. When we apply the mnemonic, the patient was just admitted. Aspen recommends starting enteral feeds within 24 to 48 hours. However, patients who are at high risk for gut ischemia, we may delay it until they are off pressors. So for feeding, there's no intervention needed yet, but we should keep our eye on this every day. Analgesia. The patient is intubated, and sepsis itself may be very painful. We should ensure a pain medication is ordered, for one is not yet on their file. We know the patient might have hemodynamic compromise based on his labs and vitals, so we should consider one that will not affect this if possible. Sedation. The patient is intubated. His RAS scores are very high. Addition of fentanyl or another sedative may help the patient be more comfortable while we take over breathing for him. Thromboembolic prophylaxis. This patient should have his DVT prophylaxis addressed every day. His platelets are low, but not to the point that we consider coagulopathic. He may have some form of septic consumption of platelets or disseminated intravascular coagulopathy, in which case we'll need to bring up on rounds the risk versus benefit of thromboprophylaxis at this point. The patient is intubated and has a coagulopathy. He is a high risk for ulcer and clinically significant bleeding. He should receive famotidine or pantoprazole for stress ulcer prophylaxis. Glycemic control. The patient has an elevated blood glucose and insulin is not ordered. He's on metformin at home, so I know he might need a more aggressive regimen than normal people. I would probably order a sliding scale C for him to begin with. And of course, we don't want to forget to elevate the head of the bed. I'm sure you had many of the same answers as I did. Congratulations on your ability to apply the FASTHUG Mnemonic to patients and improve their care. Now go out and use this.